therapy. Pulmonary tuberculosis, 1 in 50% would die.
Yeah.
And other forms of tuberculosis, meningitis.
That's right.
Everyone died.
Everyone died. Tuberculosis meningitis was 100% fatal. And even that, with the advent of antibiotics, anti-tuberculous antibiotics, that tuberculosis meningitis was generally curable after that. Sometimes they didn't make a complete recovery. They might have been left, for example, they might have been left with a bit of deafness or unsteady gait, because that could happen. But generally speaking, most of them made a complete recovery.
So thereafter you moved, you'd done yourself out of a job, effectively.
Well, yes.
Well,
no, it wasn't quite that way. I mean, there was still plenty chest illness. There's increasing numbers of malignant disease within the chest, and there was still all the other chronic diseases, obstructive airways disease and asthma and all sorts of conditions which were pretty nasty. And there was plenty of work for chest physicians. But somehow or other, I got the notion that I'd been so intrigued and got so much satisfaction out of working in this team fashion that I didn't want to just become a chap who was going to come in and look at x-rays and do bronchoscopies. And I wanted to be working closely with the nurses and the social workers and indeed with the families of the patients. So I decided I'd become a geriatrician. And I went to see the senior administrative medical officer, phoned him up and said, I want to come and talk to you. He said, come in on Monday morning. So I went in on Monday morning and we chatted. And then he said, what is it you wanted to discuss with me? And I said, I want to transfer to geriatric medicine. And he got up, walked across his office and opened the door and said to his secretary, who was sitting at a typewriter in the next room, come in. And the girl came in and he said, now repeat that in front of this witness. He won't believe that happened, but I couldn't make up a story like that because I haven't got enough imagination to put. So it certainly did happen. So that was so then I continued to do 2 sessions a week as a chest physician until my replacement arrived. And then I spent the whole time doing geriatric medicine, developing the geriatric service, because again, it had been pretty splintered and there was only one geriatrician in the city, which was remarkable because it's a city of nearly 500,000 people, and there was one chapman. Of course, he had no chance of coping with he just ran a sort of skeleton service. So I took over half the city and started developing it. And again, we had enormous support from the regional hospital board, particularly the senior administrative medical officer, Dr. Ian Campbell, was very supportive, and Alec Wellstead, who was responsible for at least some of the hospital beds, he was the secretary treasurer, and he was enormously supportive too. So that when I was developing the service, for example, we took over Southfield Hospital from the chest service. It had been a tuberculosis and chest hospital, and we took it over. It was about 100 beds, I think, and converted it to be used for geriatric patients, which was quite difficult because it was a lot of the beds were in what had been a big Victorian mansion house, and it was not really terribly suitable. But we certainly got the support that we needed. I think I got everything I asked for because the administration was on our side, and we started off, and within a few years we had an up and thriving geriatric service, and went on from there and started to do some research work. And one of the first things we did was to to take random samples of people over the age of 65 and have them along and examine them and assess them and find out what was wrong with them. We discovered a whole list of conditions which nobody knew about. I mean, things like dementia, for example. The family probably knew that they were going a bit, they were failing in some way, but nobody had ever tested them to find out what was the effect of this, how impaired was their memory, and how impaired was their ability to look after themselves. And we discovered this unreported pathology. We wrote an article in the Lancet, which I think is still quoted sometimes, and we discovered this percentage of patients who had dementia, but nobody had not been diagnosed. And even things like arthritis, they had arthritis in their hip or something like that, and they were still hobbling about, and nobody had ever really done anything about it. And of course, there wasn't, in these days, there wasn't. They were just beginning to be possible to restore a hip to normal function by replacing the joint. And so it was terribly important that these conditions should be detected early, because otherwise they were continuing to progress. And by the time they did come to notice, it was too late, because the condition had gone beyond repair or beyond effective rehabilitation. So that was very exciting to discover that there was this unknown quantity of disease, some of which could be cured, much of which, although it couldn't be cured, its progression could be slowed down. And by instituting rehabilitation services, you could restore function. Patient who had not been able to do, get in and out of the bath or to go up and downstairs and that sort of thing, we could arrange that. And those who needed help would get the help, like a home help or a district nurse coming in regularly. And the whole thing, the whole scene of health and disability, or ill health and disability in old age, was brought under some measure of control. Now that was a tremendous struggle, because we were fighting gross disinterest. A lot of people just weren't interested, and a lot of doctors weren't interested, because there was nothing exciting about it. It was regarded as very much a Cinderella specialty, and we had a great deal of missionary work to do, and getting general practitioners, first of all, to look at these patients in a different way, and if they were not functioning very well, then to refer them to the geriatric service, where they would be assessed and any tests carried out. And if they needed treatment, we would carry that out in their homes in collaboration with the GPs and the district nurses. Or if they needed admission, we would arrange for them to be admitted to the geriatric ward, where the whole staff were trained. The nurses were specially trained and were specially selected, because they took to this form of rather unfashionable activity, and the physios and physiotherapists and occupational therapists and social workers were also specially recruited, because they were specially interested, and of course we set about training people. So it became a very important part of the health service, whereas previously it had been a kind of dusty corridor way in the distance somewhere, and in the worst cases, the patient was just put to bed and left there, which of course was the worst thing you could do, because their joints would seize up and their pressure areas would become damaged, and the consequences of this unnecessary and more or less total immobilization were ghastly to the patient and to the service, because some of them then would spend the rest of their days in a state of almost complete dependency, and they might live for months, even years, in this state. So it really was a very challenging problem. But
you gave it some academic profile, I think, didn't you?
Well, there was. Scotland had a special role here because particularly in Glasgow, there's a chap called Ferguson Anderson, and he was appointed geriatrician to Glasgow, and he had been a very brilliant chap. I mean, he was a very good student, and he was a very good physician, and he was invited back to Glasgow. He'd gone to Wales to be a general physician, and one of the senior academics in Glasgow, Noah Morris, who was the professor of materia medica, not materia medica, he was professor of I can't remember, but anyway, he was a general physician, and he was a very powerful chap, and he said, we ought to develop the geriatric service. We must have geriatric service, because there were horrifying examples. There was an old workhouse, a poorhouse, and it was, there were hundreds of beds, and the old patients were admitted there, were put to bed, and that was all that happened to them. They were just left there. And Noah, who had come to this country from Russia or someplace, when he was a boy of 12, and had shot through the medical curriculum with prizes and everything, and he said we must develop the geriatric service because it was just beginning to start in parts of England. And he invited Ferguson Anderson, and he came back and immediately set to work. And he was a tremendous leader, Fergie, and he set up a team. And within a few years, they had this very thriving geriatric service in Glasgow, and it became a model. And of course, I then started the team. Well, I developed it because it was already. There was a geriatric service, but it was very understaffed. There was only one consultant, and I became the second, and we set up the team, and we got the thing going, and that was very satisfactory. But it was hard work. I mean, again, it was like being back in the kind of pioneering days of tuberculosis treatment in the early antibiotic era. And we had this, and again, it was the crux was setting up a team of doctors, nurses, physiotherapists, occupational therapists, and social workers who were all dedicated to seeing that the plight of the elderly was alleviated to the maximum level, and that worked out. And again, it couldn't have been done without the health service being there to allocate the resources. And of course that was quite difficult because it wasn't. I mean, it wasn't everybody in the management of the health service was not absolutely convinced that this was the best way to spend money. But we were lucky in Edinburgh that the senior chaps in the health service were aware. They accepted the arguments that we put forward, and Scotland actually became a very important part of the developing geriatric movement, and we had visitors from parts of England, and of course we had visitors from all over the world too in due course. And then they set up the chair of geriatric medicine, which I was appointed to in 1976. Prior to that, I'd been appointed to the chair at Liverpool, which was a new chair there. And I was there for 3 years, and then was appointed to the newly formed chair in Edinburgh, and started all over again, developing the academic side as well as the service side. And again, that was That was the last 10 years of my working life I spent doing that to, I think, very considerable success.
You should be benefiting from that in terms of care that you receive now. As a
Yes, I do. I have needed all that.